Good evening, everyone. Late afternoon. Thank you all for joining our monthly doc talks here at Dayton Outpatient Center. Again, reintroduce myself, Dr. Priyesh Mehta, board certified in pain management and interventional spine, and really, wanted to talk about a topic today that is alternatives to back surgery. And so, many of you might have seen a surgeon, throughout your life, and they might have told you, we have to have surgery. Or you might have seen, a pain doctor, your primary care doctor, and said, hey, physical therapy, injections, that's really all you can do. And so what I want to talk to you about is there is something in between that is an option for you if you're experiencing back pain, and that's a treatment called the mild procedure. And so it stands for minimally invasive lumbar decompression. And so what it's doing is really providing an option for your back pain so that we can avoid major back surgery, right? And so we're always looking for alternatives to back surgery. We know surgery has its benefits, to improve the pain occasionally, but there are certainly a lot of limitations to surgery, that being recovery from surgery, the invasiveness of surgery, the complications of surgery. And so it's very important that you talk to your pain doctor or your primary care doctor about, hey, is there something else I can do for my back pain? And so getting a second opinion is very important. And I hope this lecture, this mini lecture, can give you some options that can spark some conversation with the doctor you're seeing. And so, just some housekeeping here. Everyone hopefully is on mute. And then at the end of the talk, I'll open it up to questions that we can answer for you, as well as feel free to chat in the chat box throughout the talk. So, when we talk about pain, talk about leg pain, okay? Leg pain can be something that's been ongoing for a long time, can be really chronic in history. It can be due to neuropathic. So what that means, a lot of burning, tingling, sharp shooting pain. It can also be vascular, right? You can have swelling in the legs. You can have coloration, discoloration in the legs. You can have, pain when you're walking. And so our job as your pain physician, your pain provider, is to differentiate, where is your pain coming from? Is it coming from a vascular source, or is it coming from a nerve source, right? The nerve source being coming from your back pain. And so today, really what we're going to talk about is the nerve pain related to your back, right? And that condition is called stenosis. And so that stenosis that you have in your back is really presented like radicular pain, burning pain, sharp shooting pain that you feel down in the back of your leg, down to your feet. We call it claudication because when you walk and you start to move, those symptoms seem to get worse. And so this is really the fundamental reason why we see patients in our practice, is because they have some sort of back pain with pain radiating down the leg. Now, if we talk about what are the treatments for lumbar stenosis, and if we talk about 2-3 years ago, what treatments did we have? Conventionally, physical therapy, right? Physical therapy has its role. They can strengthen the muscles around the spine, give you support in your arthritis so that when you're doing movements like twisting, bending, moving, it's not causing severe pain, right? Physical therapy is hard. Physical therapy takes a lot to do in order to get the muscles strong so that it supports your body. Second to that is epidural injections, right? We know epidural injections have their role in calming inflammation and pain. However, what are the limitations of epidurals, right? Epidurals do have steroids in them. We have to be careful how much steroids we introduce in our body on a regular basis. Secondary, steroids can reduce pain, but they don't necessarily treat the arthritis, right? You structurally have bony overgrowth, and that overgrowth, despite controlling pain, despite controlling inflammation, will still be in that canal, and that can still, cause symptoms to reoccur later on in life. And so Epidurals have their role. They have their role of controlling inflammation, but we also know that they're not necessarily treating the structural issue. And then, again, 2 years ago, after patients have undergone physical therapy injections, what are we left with? We're left with surgery. We're left with surgery where they go in and they put hardware. They go in, they create an incision this big, and they cut out the bone and then fixate the arthritis so that when you're moving and you're functioning, you're not irritating that joint. And so we went from lower risk treatments to a more aggressive treatment. Uh, However, now what really we have are these minimal invasive options, these, alternatives to back surgery where we're basically providing improvement in reducing that structural impingement, right? Not just controlling inflammation like the epidurals do, but now we're actually removing what's narrowing that segment to give you a little bit longer term relief. And so that's where, um, options for your back pain are there for you. And so when we talk about stenosis, what does that mean? So this is a little picture of what stenosis looks like. And so normally, if you look at this yellow structure here in the middle, that's your spinal cord. What I usually like to see that spinal cord look like is almost like a heart or a circle. So nice, big, and round. However, you can see in this case, it's lost this round structure and now it's more of a triangle. And so that triangle exactly means that canal is now small. And so we call that stenosis. And so why do we develop stenosis? We can develop it from three conditions. One is a herniated disc. So this white disc that you see in front here has now pinched that space and narrowed it. The second reason we can get that stenosis is because these facets start to encroach into that canal and become really angry and narrow that space. And then the third is this pink ligament. So you can see almost looks like a piece of meat or steak. It becomes thickened over time and it narrows that space and narrows that canal. So there's three reasons why you can develop this. A lot of my patients have all three. Some of my patients have one or two of these conditions that can be driving this space. And so our job is to look at your MRI and determine what is driving the pain. So if you look on this side image, what happens is when that canal is narrowed, it creates a little kink in the hose. I like to say that. So think of this purple structure as a garden hose. And so if we have a kink in the hose, what happens to that water? It doesn't start to flow in the best direction possible. And so what our purpose with different treatments, especially this mild treatment, this minimally invasive lumbar decompression, is we try to relieve that kink. If we do an epidural steroid injection, that inflammation might calm down, but that kink is still there. If we do physical therapy, we might improve the muscles around it, but that kink is still there, right? So we need something that we can relieve the inflammation, but then also remove the kink. And so when you undergo major back surgery, what they do is they cut all the bone behind it, and then they remove that kink. And so that, again, is an option, but there are higher risk associated with that bigger surgery. So, who deals with this back pain, right? Many people, one of the most common reasons why we get patients approached to our clinic is because of back pain. Lumbar stenosis affects almost 2 million people, in the US, right? So a significant amount of patients. Almost 94% of those patients that have back pain feel pain down the leg, right? And so, this is not uncommon. This is very common, and most of you are probably dealing with some form of this type of stenosis. How do patients present? So, pain, numbness, tingling, typically when you're standing. When you walk, you feel that pain down the leg. What relieves the pain? Typically sitting, maybe sitting in your recliner, or you go to the grocery store and you have to hold on to that shopping cart, right? You hold on to that shopping cart, you can walk through the aisles, do your groceries, but then if you stand and stop, you feel all that pain, right? So when you're bending forward, you're relieving pressure onto that nerve. However, when you're standing, you're causing more compression, right? And so a lot of my patients, they hold on to that grocery cart in order to move better, or hold on to a cane or hold on to a walker. They kind of lean forward to help relieve those symptoms. Here's what it looks like on the MRI. So I showed you that anatomical picture before, but basically, this white structure here is your spinal cord and spinal canal, and instead of being again that circle or that heart shape, it's now a triangle. And so that indicates to us that there's a lot of pinching in that space. So let's go into, what is the mild procedure and why we do that. Again, we do it for treating lumbar stenosis, right? Narrowing of that space, narrowing that canal. How do we do it? We do it in our outpatient center. We do it with a little bit of IV anesthesia. And so we create a small little port-like incision, basically the size of an aspirin. And we go in with this debulking ligament, and we actually take out that hypertrophy ligament, that thick ligament that almost looked like a piece of meat that was narrowing that space. Nothing is left in there. We remove the instrumentation, and we do this all under X-ray so that we can really see how much we have removed. What are some of the highlights of this procedure? One, there's no general anesthesia, right? So when you go through major surgery, you go through general anesthesia. With this procedure, there's no anesthesia except IV anesthesia. No stitches, no implants, nothing is placed in the skin. There's low complications, right? So the way we do this is almost like doing an injection. We do it like an epidural steroid where we use X-ray and we guide the instrumentation under X-ray. You can resume activities the next day. And so typically my patients, because there's no stitches or anything, they're able to go back to normal activities. Usually we start some sort of exercise or therapy program a week or two after. But basically you should start to feel relief, if not the next day, a couple days after. So what do patients report as far as improvement? The two main things that patients report to me are walking distance, right? So, I have a lot of patients that have trouble making it to their mailbox. Now, after we do this procedure, they can say, I can make it to the mailbox, and then I can make it down the block. Okay. So it's really that distance of improvement walking that is substantial for us and how we did with the procedure. Second thing is around the grocery store or the mall, right? I can now walk up and down the aisles without stopping. I can go around the mall and kind of do some shopping, right? So those are the things that to us as clinicians are important in understanding, hey, did this therapy actually work for you? And so they looked at, they studied this, they really looked at patients and how they did out to almost a year time. And over the course of the year, all these patients got better in their distance of walking and also the time that they were able to stand. They also looked at, what do the patients look like when they have different diseases, right? So, back pain is just a general term, but patients with back pain have muscle pain, have the stenosis pain, have disc pain. And so what they looked at is that patients that underwent this treatment, even though they had all these other conditions going on, how well did they do? And so the data shows that, 76 to, 72 to 77% of patients did get better with this treatment, regardless of what type of back pain that they had. This is looking at how safe is this procedure. So we look at, anything that we do, we want to make sure it's very safe. And so if you look at the mild procedure, which is this in the blue, what are the complications? Less than 1% complication rate. What about the big procedure, surgical fusion? You're looking at 9 to 12%, 18% complication rate, right? So that is a significant portion of complications that, again, if you're weighing the pros and cons of surgery, we have to really see if it's surgery is necessary in that standpoint. So considering the mild, it's a very safe, a very approachable procedure that we can do in our outpatient setting. Does insurance cover this, right? So Medicare covers this procedure. Medicare and the Medicare, Advantage plans, they all cover this procedure very well. We've been doing this for the last 5 years of this procedure, and hopefully we are seeing commercial insurances start to cover it, Medicaid hopefully start to cover it, and so I think the data is there to really support the use of this treatment. So what we're doing here is, again, having back pain. You can hear my head, right? Okay. And so what we do is under X-ray, we give a little IV sedation, and under X-ray, we numb the skin. Looking at where the pinching is of the canal. And what I do with an injection is I inject some contrast. And so what that's going to do is show me where the kinking of that hose is. Okay, it's going to show me exactly where I need to go. And then what we do is with some instrumentation, a cannula, as I go in to that area that's kinked, using this little tool, I go ahead and remove that fragment that's actually pinching that space. And so what that's going to do is relieve that pressure on that cord or relieve the pressure on that tube so that now that nerve has more room to breathe. And so after that, you'll have, a bandage on your back, a Band-Aid, and then we'll follow up with you in the office to really see how things have worked. And so this is, it takes about 5 to 10 minutes under IV anesthesia, and we can do multiple levels. Typically, we do one, if not two levels, depending where that area is narrowed. And so, again, that's just a short clip that you can view, on our website in the conditions tab there for you. So are there any other questions that I can answer for anyone?
Yes, my name is Peter Hess. A question that I have is if it is a disc that is uh, expanded and touching the nerve, does this procedure address that?
Yes, great question. So the question was if there's a disc herniation pressing on the nerve, will this procedure address that? So no. So this procedure is specifically geared for thickening of the ligament. So thickening of the structure. Let me show you here. The pink ligament that's narrowing that space. And so,
Okay, I can't see. We're not seeing that picture. Also, I have another question.
now you see it, the pink ligament.
Yeah, I see it now.
Yes. So that is what's actually narrowing the canal. And so rarely do we find in patients over, 40, do they only have an isolated herniated disc? They usually have some thickening of that ligament that's contributing to that narrowing.
Will this procedure identify what is the problem, whether it's a disc um, 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 enlargement or whether it is the ligament?
Yeah, good question. So typically patients that have disc-related pain have more pain with sitting, have more pain with standing for a long time. However, patients with stenosis, that have this thickened ligament, have some relief with sitting, have some relief with bending forward. And so that's where we can differentiate where's the pain coming from. Is it the disc or is the ligament that's driving that pain? There might be some overlap, but again, typical hallmark of stenosis, which is what this treatment is for, is the back pain radiating down the leg because of this thickened ligament.
Okay, with me, the biggest problem is standing for long periods of time. So this procedure should address that, or should address where the problem, what the problem is, what's causing the problem.
Yeah, so again, this treatment is for back pain with leg pain, right? So if you have back pain with standing and then you start to get, when you stand for a period of time, shooting pain down the legs, that might fall into this category, right? But if you don't get any of that radicular pain or pain shooting down the legs during that prolonged standing, then we have to look at a different picture as to what could be driving the pain. And so, again, that classic symptom sign is pain with walking, shooting down the leg. You have to hold on to that grocery cart when you're at the grocery store.
Okay, a question I was trying to ask earlier is that I don't have Medicare Advantage, but I do have Medicare Supplemental AARP. Is it covered? Is a procedure covered with that?
Yes. Yep. AARP, Medicare, and any Medicare supplement is 100% covered.
Yes, I've been had a pamphlet about this and everything, and I have bulging, protruding, and disc in my back. And when I walk with the walker because I can't. If I'm like you said, leaning in, that makes it feel better. Sitting down makes it feel better, but the pain is still steady, always there. And I do want this procedure to happen because I don't want to have to go to the thicker, deeper other one like that. Um, but will I be able to walk without my walker once I had this procedure?
Yeah, so again, every goal is different, right? So if by the fact that you're leaning forward, you're holding
Mm-hmm.
onto your walker, you're compensating. You're trying
Right.
to actually open up that space. So if we go in and we actually remove the ligament that's narrowing that space, the idea is that can you stand up more straighter? Your body's
Mm-hmm.
not going to have to compensate and kind of bend forward. So that is one of the functional goals, right? It's not just distance, not being able to walk further, it's being able to stand up straighter, have
Okay.
your muscles not take a lot of that load and a lot of that work now because they're not compensating as much because of the pain. That's the idea, right? And so we
That's what
transition
I
from a
need.
walker maybe to a cane and then maybe eventually out of the cane. And so that's where physical therapy and exercise and strengthening the muscles can help even after we do this procedure so that you can maintain your body strength and your core.
Okay. And once you do the procedure, how often will I have to get it done? Does it get back in there and pinch it again where you have to go back in there and get that out, or how long does
Yeah,
it last?
very, very good question. So once we remove the ligament, we
Mm-hmm.
remove it, right? So it's not a procedure that we need to go back in and do again. Now,
Okay.
if you were say this worked for 4 or 5 years and helped you
Okay.
get better and say the pain got worse
Mm-hmm.
because of arthritis and other areas causing the pain,
Mm-hmm.
you can still undergo back surgery, right? You can still undergo an epidural steroid pain. You can still undergo other treatments. It's not going to affect that, but I do this once. I treat as many levels as I can at one time to really get as much removed as we can.
Okay. But having that ligament there, can it be in more ligaments in different places or just that one ligament in that one position? You know what I'm saying?
Yeah, so each level has that ligament. And so think of the ligament as continuous. So
Okay.
if I pull this picture here, you can see that.
Okay.
So this green ligament is basically throughout your whole spinal canal. And so
Okay.
we remove the part that's thickened. And so you still have some ligament there that's supporting your back, but we're removing the part that's actually kinking the space.
Okay. Because I had been told about a procedure where you do the same, like you saying that little slit that you put in, and then they put like a little wedge because I'm having a problem with my vertebrae. I guess my cartilage or whatever is gone or leaving, and my vertebrae are just like rubbing bone. Does that help that?
Sorry, I couldn't hear you on that one. What was your question?
Okay, my vertebrae. They said there's another procedure that you can do, and they put a wedge in between the vertebrae where it's not pressing down on each other, causing the pain.
So I might have missed all of it, but if
It's a,
the if the
it's a,
vertebrae is compressing it, it's
yeah.
not going to increase that height. It's just going to relieve that narrowing of that space.
Okay, so do the PSI. It's a chart y'all have there in the office when I'm seeing Miss Jackie, Dr. Jackie. They say PSI. I guess it's the SI thing. Is that like this, or exactly like this, or not the
Yeah,
same?
so this SI joint and SI pain is kind of different. This is really just controlling that back pain and sciatica pain that you're having.
Okay. So
Yep,
when
good
can I
question.
sign up? I'm ready. That's all the questions I have. Thank you.
Okay, thank you, Barbara. Are there any other questions?
Can you hear me, Doc?
Yes, I can hear you.
All right. Guess I'm supposed to have the halt box put in, or should I skip and go straight to this?
Sorry, say that again. You had what?
I'm supposed to have the box implant for the stimulation.
Okay.
Should I skip that and go straight to this, or
So again, I would have to look at, what your back looks like, but stimulation is treating something else, right? So that's treating more of the chronic pain related to the nerve structure. So um, you've probably already tried the epidurals. You probably already tried different injections for your back to treat the
yep,
stenosis as much as we can. I think if we were to look at your spine, you might have more than one level that maybe this mild wouldn't be the best indication for. And so neurostimulation is going to treat kind of a bigger picture. But without going into detail with what your anatomy looks like, it's hard to say, whether this is beneficial prior to that.
well, I got an appointment tomorrow with one of the doctors. Should I talk to them about this?
Yeah, talk to them about your symptoms. That neuromodulation is a good treatment to treat kind of the broad picture, right? Treat a lot of neuropathic pain, diabetic neuropathy, leg pain, back pain.
Okay.
This is treating one specific area, one
Once.
specific
All right.
issue,
All
which
right.
can help. But I'm guessing in your case, we need something bigger picture to help with your overall pain. But
Yeah.
yeah, discuss with your provider tomorrow and see what they say.
Okay. Thank you.
Dr. Mehta,
Yes.
does this only work for the low back? Is it something that could work for any other, like I have really bad neck problems? Is this specific to the low back?
Specific to low back right now. Yes.
Okay.
And so that's where the most of the thickening of the ligament happens. And so that's what it's approved for under insurance, and that's where the most of the data is.
And what
Um,
would you need? You need an MRI, CT scan. What do you need to determine whether or not you're a candidate? Or is it only if you have the pain when standing?
I'm sorry, say that again.
What do you need to determine if you're a candidate versus I have pain when standing? My pain is sitting, so I don't have pain when standing. But if you need to see a CT scan, an MRI, an X-ray, what would make that determination?
Yes, an MRI.
Okay.
MRI is going to be determining factor for me because what I like to see on the MRI, if you can see in this image, is that triangle formation. And so we measure the actual ligament to determine how thickened it is.
Okay.
And so that's typically what we need to see. Now, your picture is a little bit mixed because you get pain with sitting, typically relief we get with sitting. And so we just have to kind of see where the pain generator is and determine what's the next step. And
Okay.
so one thing I should mention before we do the mild is I always do an epidural steroid injection to know exactly what level is causing the pain, right? If you take an MRI, you can see, maybe patient has multiple levels where there's stenosis, but only one area is really driving the pain. And so the epidural steroid injection is helpful for me to know, hey, this is where the pain is coming from, and this is what we should treat when we do the mild. And so we use it for diagnostic and therapeutic purposes to preoperative plan for this procedure also.
And this would work whether or not you have a fusion. Like if you already have a fusion and this is years ago and your pain is chronic, is this also something that could work if you have the fusion?
So, no. So once you've had a fusion, you can't treat that level, but we know what happens when we have a fusion. When we have a fusion, the levels above and below start to take that load. And so we can treat those adjacent segment levels. So we can start to treat the stenosis at the level and above and below where you had surgery.
Okay, thank you.
Mhm. Great. Well, thank you everyone for your time, on this beautiful day outside to learn about alternatives to alternatives to surgery, options for your back pain. Hopefully this was educational for you, and look forward to you talking to me or talking to your provider about what we can do for your back pain aside from surgery. And then please tune in next month for our next lecture coming up.
Okay, can you hear me?
Yes.
Before you leave now, if I want to get this done, do I got to make an appointment or wait till I see my doctor again, or because we have
Yeah,
already
so
talked
we
about it?
we will send a follow-up email,
Okay.
regarding with the presentation and everything, but we have a note of everyone on this lecture, and so I'll make a note for your provider to reach out to you directly.
Thank you. Appreciate it.
All right, everyone. Thank you so much for your time.
Have a great day.
Bye-bye.